Hello, everyone, and welcome to Advancing Innovative Finance for NTD. My name is Aissatou Diawara, and I'm a technical advisor at Glide. So thank you for joining. We're excited to have you here today. We're just going to wait a few more minutes to give everyone a chance to join before we get started. But in the meantime, feel free to introduce yourself using the chat box. So more participants are joining. Welcome, everyone. Feel free to introduce yourself in the chat box before we get started. So for new participants who just joined, so welcome to our webinar, Advancing Innovative Finance for NTD. So my name is Aissatou Diawara. I'm a technical advisor at Glide. So we're going to wait a few more participants to join, and we will be ready to start the webinar. So you can use the chat box to introduce yourself. So I just received messaging saying that the chat box isn't working, but I can see participants' messages. So we're just troubleshooting it. So welcome, everyone. Welcome to the Advancing Innovative Finance for NTD. My name is Aissatou Diawara, and we will start shortly. Thank you for joining. So I think we're ready to start now. So hello, everyone, and welcome again to Advancing Innovative Finance for NTD. My name is Aissatou Diawara. I'm a technical advisor at Glide, and thank you again for joining. We're excited to have you here today, and we hope that you will find this webinar informative and engaging. So before we begin, I'd like to provide a few housekeeping instructions. So all participants will be muted throughout the webinar. And if you have any questions for the panelists or comments, feel free to use the chat box located on your screen, and our team will be monitoring the chat box and will do our best to answer your questions during the Q&A session. We will also have a simultaneous translation available in French and English. You can click on the translation icon to choose your preferred language. And finally, today's webinar is being recorded and the link will be shared afterwards. So I will now hand over to Dr. Ngozi, who is our moderator of the webinar today. Over to you, Ngozi.
Thank you so much, Dr. Diawara. If I can just echo what Dr. Diawara said and welcome you all warmly, and especially the speakers and all of the audience members. GLIDE is really privileged to be working in this space. So why are we talking about finance mechanisms for NTDs now? Well, during the last NTD Day, which was January 30th, about 2 weeks ago, WHO shared the great progress made globally towards the WHO roadmap elimination targets. For example, in 2022, 8 countries eliminated at least one NTD. Now, we all know that this is tremendous news, and a lot of this progress is due to the availability of donated preventive chemotherapies and the consistency of NTD programs to get these drugs to at-risk populations. But it's also a result of investments in safe water, sanitation, and hygiene efforts, as well as community participation and leadership. But while all this progress is important, we have much further to go. And as the old saying says, what got us here is not necessarily what will get us to where we want to be. The truth is COVID-19 negatively impacted health facility access and disrupted supply chains. And the current global economic situation has resulted in significant cuts to overseas development aid for NTDs. There's also a lack of effective diagnostics of more than 70% of NTDs. And there's a challenge to find more effective treatment due to the lack of investments in research and development. So why are we doing this now? Well, it's because 1.7 billion people globally are affected by NTDs, with 500,000 people dying either directly or indirectly from NTDs each year. And because climate change can potentially set back the progress made and exacerbate the current challenges. And finally, because on the 5th of January, WHO said it is more urgent now more than ever that endemic countries and global entities across public and private domains act now, act together, and invest in neglected tropical diseases. So today we're coming together to reignite conversations about developing sustainable finance mechanisms that can successfully combat NTDs. Over the past year, GLIDE and any stakeholders across several sectors convened regularly to interrogate and discuss which instruments could plug gaps in the NTD value chain. We looked at finance instruments that have not yet been applied to NTDs, though they may have been applied to other diseases. And this is the innovation. The result of this work is a discussion paper that all the speakers and panelists have read and will provide reflections on today. This discussion paper looks at 4 finance mechanisms and discusses opportunities to apply them to NTDs. But this is just the beginning of the exercise. There's much more ground that needs to be done to understand from endemic countries, are these finance instruments realistic in the light of their economic realities and country priorities? Also, we want to hear from experts who have designed and employed such instruments and see if they think that these instruments can be applied to NTDs. Especially these NTDs often have a much lower burden than malaria and TB, which a lot of the other innovative finance instruments have been applied to. The discussion paper is available now on the GLIDE website, and we will add the link to the chat. And just quickly, an overview of today's talk. We have 3 parts. The first section of the discussion is our speakers will frame the discussion and kind of talk about the different challenges from different perspectives. In part 2, we have speakers that will reflect on the specific instruments that we outline in the paper, and they will put their insights. And in the final section, GLIDE CEO Simon Bland and Acting Africa CDC Director Dr. Ahmed Ogwell Ulma will provide reflections about the discussion so far and provide insights on a way forward. Now, we will have at least 15 minutes at the end for questions and answers. So without further ado, I'd like to introduce our first speaker, who is Dr. Dr. Ima Sosei-Fall, who is the Director of the Department of Control for Neglected Tropical Diseases at the World Health Organization. Most recently, Dr. Fall served as the Assistant Director General in charge of WHO's emergency response. During his term, he led the organization's response to high-impact epidemics, humanitarian crises, and acute public health events at the global level. Dr. Fall, over to you with thanks.
Thank you, Dr. Ngozi. Can you hear me?
Yes, we can hear you. Please go ahead.
Okay. Thank you very much for inviting me to speak today. Many thanks to GLIDE for its leadership and for organizing this important event. I'm very glad to see so many friends, colleagues, and partners connecting to attend this important event. And as we all know, neglected tropical diseases, which we commonly refer to as NTDs, are diseases of poverty. They exert an unacceptable and disproportionate burden to the world's most vulnerable populations. As a diverse group of some 20 diseases, they have one thing in common, which is the suffering and hardship they inflict on people from whom life is already extremely difficult. In 2019, for example, the NTD caused an estimated 200,000 deaths worldwide and were responsible for 14.5 million years of healthy life lost as a result of disability. This inevitably means too that the NTD lead to terrible financial hardship for the people who suffer from them. They directly affect people's ability to provide for their families, affecting the incomes and livelihood they are able to generate. And primarily touching family members aged 15 and 49 years, they also take a terrible toll on school-age children, meaning that if they are not addressed, the financial consequences of NTD can last a lifetime. We have had some genuinely impressive progress, as you just highlighted, and today 47 countries have eliminated one or more NTD, and millions of people are no longer at risk of suffering from NTDs. This is to be celebrated for sure. But we still have a long way to go to reach the 2030 NTD target. And unfortunately, we will not reach this if we continue at the same pace we have been on so far. We must embrace and fully commit to the shifts outlined in the 2030 roadmap, and that include changing the way we look the fund and resources of NTD intervention. There is a pressing need to ensure better as well as more investment, and this means encouraging and guiding investors to invest wisely and with greater flexibility. It means recognizing that sometimes you will only be able to specify, expect, and hope for outcomes in collaboration with local context-specific actors. And it means accepting that those closest to the intervention being administered will often be the best place to advise on the allocation of funds. We are all well aware too that we find ourselves in the changing funding landscape. COVID-19 had an impact on programs, but it has also impacted global health policy and funding. Global priorities have changed, and there is much less interest now in vertical programming. Major funding gaps are appearing in the NTD world, and previously successful solutions are not going to be the ones we can turn to much longer. This is why we have to explore all the options available to us to ensure that we have enough resources to accelerate progress towards the 2030 roadmap targets. I come to NTDs only recently, moving from the field, the health emergency field, as you just said. Also, I worked many years ago in NTDs. I have been struck by a number of things. However, Since coming into this position in the first place, NTD budget is much more smaller in comparison to health emergencies. But it is really noticeable to how NTDs play a fundamental role in a number of global health agendas, core components. We must emphasize this point to ensure that our financing is focused on concrete outcomes, not only on the funding that goes into our programs, and to ensure also that the external or programmatic financing is able to mobilize and make the most of local and national government resources. Investment in NTDs is an investment to the wider global health agenda. The links between NTDs and new and emerging health emergencies, this pandemic preparedness should be made clear in financing proposal as well as in implementation and governance. Very often the people who carry out activities like surveillance, cross-border surveillance for outbreak will be exactly the same people carrying out surveillance intervention for NTDs. We need this to be better reflected using budget at national, regional, and global level. More flexible channeling of resources towards priority areas can also make our intervention more effective and efficient. Investment in better diagnosis, for example, stronger monitoring and evaluation platforms, and more efficient supply and logistics chain can and will bring results. We must look to collaborate to harness the power of intervention being carried out in other fields such as water, sanitation, and hygiene in the spirit of One Health, and to bring other areas into our work to take them along with us. For NTDs intervention are also a crucial component of the drive towards universal health coverage. They provide vital access to impoverished communities to healthcare services, and they can be frontline leaders in global effort to mitigate the effect of climate change. It is vitally important that WHO takes the lead in ensuring that these links are highlighted and strengthened so that we can translate into better and more coordinating resourcing strategies at the individual country level. In the first place, however, we really have to get to the grid with the costing gaps in our program and committed to bring together partners so that we can properly identify and prioritize those funding gaps, which will be critical to meeting our 2030 roadmap targets. As I say, my own NTD journey is only just beginning, but already I've been deeply impressed by the passion and the drive shown every day by many partners who make up the diverse and very rich, committed NTD community. Together, you have invested your time, energy, and resources in making the progress we have seen today. I want us to protect, develop, and deepen the progress. That means resourcing ourselves adequately and sustainably from now on. That's why we must come together to explore the solution we all need to ensure lasting and continuous success in the future. I thank you.
Many thank you. Many thanks, Dr. Sose, for that excellent introduction to the issue. You're completely right. We're appreciative of WHO's leadership and of the NTD community. And so to continue on the framing of the issues, we have the expert stakeholders that are part of the NTD community. I'm going to read all of their backgrounds before I invite the first speaker to speak. So our first speaker is Dr. Takayuki Hida. He's the Senior Director of Sustainability for Eisai Limited. He started his career in drug discovery, and then Dr. Taka became a WHO focal point in 2013 during Eisai's participation in the WHO global program to eliminate lymphatic filariasis. He has since led global partnerships on neglected tropical diseases, including the NTDs group on the Japan Pharmaceutical Manufacturers Association. He currently drives company strategies related to ESG from a partnership and social issue solving standpoint. The second speaker will be Dr. FIFA Raman, who is the lead of the Matahari Global Consulting Company. She's the principal consultant, I apologize, for this company, and was the permanent NGO representative on the Facilitation Council of the WHO Access to COVID-19 Tools Accelerator. Dr. Rahman is a global health specialist working on the global COVID-19 response, including access barriers, pandemic preparedness and response, anti-racism and global health, and the effects of the COVID-19 response on HIV and TB services, as well as access to essential diagnostics. Dr. Rahman has actually provided us a recording that we will play today. And our third speaker for this segment of the webinar is Dr. Willow Brock. He is the Vice President and External Relations at FIND. Dr. Brock has an international development profession spanning 25 years of profits in implementing MBA principles, partnership development, and fundraising growth. And he's also adept in institutional, corporate, and major donor fundraising, as well as managing marketing and communications. He has more than 10 years of global consulting, training, coaching, and project management experience, and he currently leads external affairs at FIND, working between Geneva, Brussels, Berlin, and London. He excels in leading interdisciplinary teams to achieve results. So without further ado, we will have our speaker speak. Over to you, Dr. Taka.
Luigi, thank you very much for introduction. Can you hear me?
Yes, we hear you well. Thank you.
Okay. Thank you very much, the organizer and the grad colleagues, for this opportunity and inviting me this. And hello, everyone. My name is Takayuki Hida, working at the Eisai, a pharmaceutical company based in Tokyo. As Ngozi introduced, Eisai is committed to the WHO program to eliminate lymphatic filariasis, started in 2010. After successful development of DC tablet, we initiated providing DC free of charge, starting 2013. To date, we shipped 2.1 billion tablets for 29 countries. Second commitment as Eisai, as you may know, the Global Health Innovative Technology Fund, GHIT Fund. The GHIT Fund is acting an important player to invest the innovation of NTDs. Eisai is one of the founding partner to the GHIT, and another side, Eisai is developing new drugs for NTDs, having an investment from GHIT. Today, I would like to touch on 2 points. First one is impact of drug donation, and second one is issues to delivering new treatments of NTDs. And I would like to move on to the first point, the social impact of donation drugs. There is no doubt that donation programs by pharma companies are critical and have had a large impact for the elimination program itself. WHO announced the LF program made 17 countries free from LF, and people affected are declined 74%. I understand it is difficult to showcase the economic impact of drugs in general, but I feel the visualization of the social impact or social value is getting important. Professor Yanagi, he is the former chief financial officer of Eisai, our company, tried to visualize the social impact of DC donation in joint research with Harvard. And it is estimated that the value creation by DC tablet is equivalent about 600 billion US dollar with the 1.6 billion DC in the period of 2014 and 18 for 5 years. He published the result in the Japanese journal, and the research summary was posted in our website. That this result attracts the interest of long-term investors as a case of impact accounting towards tackling social issues. In addition, from the perspective of the visualization of non-financial corporate value, it is recognized as an advanced case study for promoting investment. This is one suggestion, attempting impact visualization and the involvement of the investors, such as ESG investors, into the discussion of NTDs might create some innovative solution in finance. And second point is issues. ASI and other pharma companies are strongly committed to their donation programs. However, this is not sustainable for all companies and diseases. In addition, we need to consider how access to innovative new products will be supported. I should say that current global mechanism to support delivering innovation is not sustainable if the donation is the only method. I'm leading the discussion, the industry group. Many member companies receive investment from the GHEAD. The biggest and the highest issue is the global health architecture. We are concerned the sustainability of the drug delivery lacks of a mechanism to ensure sustainable access to NTD new drugs. Some companies are hesitant to entering research for NTD drug development. I would raise the necessity of strategic discussion from the research to manufacturing and delivery of innovative products for NTDs in the comprehensive manner. Finally, to the situation moving forward, as an NTD community in Japan, we are working together to use the opportunity of G7 Summit, hosted by Japan this year. We submitted the proposal paper for G7 to the government of Japan. We must consider the delivery of innovation for NTD to the front line, and we are urging governments to consider the possibility of expanding the existing mechanism of procurement drugs, since the government seems to think that it is not appropriate timing to propose a new mechanism. So I will be committed to delivering innovation, believing that new innovative drugs and tests have a potential to change the scenario of NTD roadmap. Thank you for your attention.
Thank you so much, Dr. It's very important to hear about the work that ESI and other drug donation programs have done to combat NTDs. So our next speaker is Dr. FIFA Rahman, and we will play her recording now. Thank you.
Good morning, good afternoon, and good evening to all colleagues at the meeting today. My apologies in advance that I couldn't be live with you today. I wanted to be able to provide some comments from the civil society perspective on what needs to be done on NTDs and where the largest gaps are. Madagascar, for example, we know anecdotally and through our engagement with communities that there are many children just waiting and waiting and waiting for their results, schistosomiasis and other neglected tropical diseases, simply because diagnostic systems aren't strong enough and there is no universal health coverage, so everyone has to pay for it. And in other countries where we work, for example, in Nigeria, where, of course, continues to shoulder 25% of Africa's NTD burden, we've just got a massive neglect in terms of donor funding for NTDs, and a failure to really integrate NTD work into existing initiatives that they're doing. And an example of this is, of course, water and sanitation work, where we don't really see, people talk about One Health all the time, but we're not really seeing investments in WASH being connected, for example, to neglected tropical diseases, and we're not seeing that in diagnostics work as well. So now that we have a real opportunity with the WHO diagnostics resolution, which of course states that urges member states to invest in national strategic plans for diagnostics, this is something that we can press on, because it's incredibly important that point of care diagnostics are available for NTDs in LMICs, and that these are affordable, subsidized and or free, which is most important. What do we want in terms of what we want, not just from countries, but also from donors? So from donors, it's incredibly important to have integration of NTDs into their existing investments, on whether it's on WASH or on diagnostics or on pooled procurement. And pooled procurement is incredibly important, as you mentioned in the white paper. In terms of what countries need to do, there needs to be increased investment for research and development, and also on really funding and integrating existing strategies with NTD work. Ultimately, we're a little concerned that there hasn't been enough integration. Everybody's talking about One Health, but nobody's really talking about the nitty-gritty of what that involves. In the context of NTDs, we hear it a lot in terms of the context of pandemics, but it really needs to be focused on and needs to be packaged in a way that donors find appealing. A lot of donors we find want quick wins, and quick wins look good for your taxpayers, but it really doesn't solve the situation at hand is monumental. And I look forward to hearing from all of you on the results of this discussion. Thanks very much.
Thank you to Dr. FIFO, who actually joined or recorded that on her honeymoon. We're really appreciative. But she really important remarks about civil society, pushing for more integration and increased investments to access for point of care diagnostics. And to, I think, go further in diagnostics, our third speaker, Willow Brock, will continue. Over to you, Willow. Thank you.
Thank you, Ngozi. I'm hoping everyone can hear me well. It's glad to see sort of from the previous introductions that everyone recognizes the importance of diagnostics, both for obviously patient care, but also for surveillance and understanding the fact that the NTD numbers we are sort of reliable. I would at the same time point out that investments in new diagnostics has been limited compared to drugs and vaccines, representing only about 5% of the R&D investment. So there's some work that we need to do there. Just to give a little bit of a snapshot, 6 of the neglected tropical diseases on the list that WHO publishes has no diagnostic test at all. So there's a big need to either adapt, modify, or do new development into these diseases and ensure we have proper diagnostics. 16 diseases on the list have tools, but similarly need to be adapted to reach the 2030 targets. They're either not specific or enough, or are not able to basically go down to field level at primary healthcare, where we really need patients to be covered from a testing. There is therefore an urgent need for the development of new tools. And what we also need to see is that newer diagnostics like rapid and multiplex diagnostic tests that exist for certain NTDs have been developed, but procurement and supply of these must be strengthened. So this is very similar to what my previous colleagues have said. Now let me put on my economics hat and sort of talk a bit about the study we've done and what we've called innovative finance. And first of all, as an economist, I'd like to say there's not much innovative we've actually come up with. We have basically said, how can we use tools that we know exists? So this is not something that needs the world's bankers to change their mentality. It's how do we apply them to neglected tropical diseases? So first of all, we know that if you look at diagnostics, very few developers engage in NTDs. If you contrast that, for instance, to COVID-19, where we had 1,200 diagnostic tests developed in a year. However, even for COVID, we saw that many of those developers and available tools never made it to markets in LMICs. So for most NTDs, diagnostics are called a market failure. But if you look at really the numbers of patients, if you look at the price levels, if you look at the economic impact, it is viable to attract private investment. It doesn't mean that there is no return on investment. So I think we should stop calling it a market failure. The markets fail. It's not the NTDs that are the problem, it's the markets. So second of all, I think what we have seen over COVID, and this is again a bit of a technical solution, we have seen so much progress in diagnostic innovation that we now are in a very different place in terms of platforms that can be adapted. So rather than having to invest in fully new diagnostic platforms, we can now adapt existing technologies to include NTDs, and that's a lot lower cost. That means your investments go down for a much higher impact than we've ever had in the past. There's a few good things about pandemics, but this one is at least one of them, luckily. Then from an economics point of view, and when you start listening to the next presentations on the technical solutions we propose, there's never going to be a one-size-fits-all for all NTD diagnostics combined. There are 22 diseases on the list, and they're all very different in terms of their disease burden, their progress towards elimination, their targets, and their complexity as a disease. So for each NTD in itself, we need to be very specific in saying which tool and which financing mechanism fits which disease for which countries. Then my real economy hat, we know markets behave very consistently. We sometimes say they don't, but they are extreme consistent, sadly. They may not always give us the focus and results we want from a social development perspective, but this is not to say that there's inconsistency. The nice thing about infectious diseases is we know how to deal with them. I mean, WHO has given the roadmaps for most diseases for test and treat. We know how the path to elimination looks like. We're looking at implementation. We're not looking at not understanding these diseases, not knowing what is there. We may lack some tools, but we know the pathway. Now, what does that mean from an economist? It means we have a clear path to elimination, which means that in a few years, you have to invest heavily in a few years, and then you have an eternal stream of revenue that is a benefit from that investment you're now making for elimination. What that means is almost any NTD that has an elimination target can have a positive return on investment that is really significant from a financial and economic point of view. So we have to stop worrying about the fact whether there is a tool that, economically speaking, there is. What we need to do, however, is be bold and be ambitious, because if we just want to try to control NTDs, we will have an eternal small market with eternal expenses and revenues that are not massive. So then the proposition from an economist point of view is much smaller. If we look at our targets for 2030, we know that we can actually achieve those. We know it needs a fairly massive investment, relatively speaking, for 5 or 10 years, but then an eternal stream of revenue. So each of the financial tools on the market are in principle going to be positive if you evaluate them with an elimination mindset. So that's what we need to do in the NTDs. Be bold, be really committed to elimination, and then work to finances around that. So countries affected by NTDs should therefore consider employing financial solutions to protect the progress made today and crucially expand to elimination successes, right? And innovative mechanism in that sense must then be catalytic. It doesn't mean you can take away the grant funding. We know that's important, and there is a good reason for it, and we need to keep them, and financing solutions should come on top. So these were the couple of things that I want to give you before you start listening, because I want everyone to remember that every of this next session's examples is really achievable, and it will lead us jointly as an NTD community to an ability to really claim success by eliminating these diseases. Thank you, Ngozi. Over back to you.
Thank you so much, Willow. We really appreciate that reframing, as you said, to an elimination mindset, so we can have big investment now and returns in the future. All right, thank you to all the speakers that just framed the issue from us from different perspectives. Now on to our second part of the webinar today. Again, the second part of the webinar will be for colleagues to reflect on the 4 instruments that were listed in the discussion paper. For the first instrument, it will be debt swaps, and we have 2 speakers that will speak on this. Let me give you a short bio. The first speaker, the speakers are Bryce Kleborn-Berube and Vladis Tikarakis. Apologies if that was pronounced incorrectly, I apologize. And both of these colleagues, both of these speakers are with the Global Fund. Bryce is an innovative finance officer, and he joined the Global Fund in May 2021 as a consultant to support innovative finance within the Health Financing Department. He's responsible for all debtor side coordination for the Global Fund's Debt to Health Financing Department. Prior to joining Global Fund, he worked as an auditor for KPMG UK, a social performance, and he was also a social performance lead at a South African microfinance institution. Bryce has also worked in a Greek refugee crisis as a humanitarian actor. With Bryce will be Vladis Tikarakis, and he is a program coordinator of Debt to Health. Vladis arrived in Geneva in 2008, and he's worked for 4 years in microfinance investments in an advisory role, and more recently in supporting the business franchise strategy at Merck Serono. Prior to that, he worked for 4 years for the International Finance Corporation, which is the private sector arm of the World Bank. He has worked on projects to implement HIV awareness, prevention, and treatment programs, and then as well on the private equity investments in emerging markets. So without further ado, Bryce and Vlasis, over to you.
Thanks very much, Ngozi, and everyone. Thank you for your attention. Glad to be here. I will start by introducing and saying a little bit about the Global Fund. I think many participants here know what the Global Fund is, but it's also a way for me to convey the point that far more than building a solution called innovative finance, called debt to health, called debt swaps, what you really need to build underneath it all is the foundation, something that ensures a proper implementation of the debt swap. We did not come up with a debt swap solution as a hammer, and then we were looking for the right nail to beat. We had the Global Fund introduce a methodology commonly accepted by donors and implementing countries on how to implement at scale health programs against AIDS, TB, malaria. And this came up with the problems. And then we started thinking, okay, what are the innovative financial tools can solve those problems? So very briefly, the Global Fund was started 20 years ago. We are fundraising and disbursing around 4 billion every year to more than 100 countries. Since 20 years ago, we have saved 50 million lives. And we have fundraised in our last fundraising replenishment conference, as we call it in the US, close to $16 billion. This is very important to note because debt swaps as a solution comes to complement this kind of foundation. I'll give you a stylized example of how this looks like for Indonesia. And I will then pass it on to Bryce to explain also the Indonesia experience if we have time. As I said, the Global Fund fundraises, then allocates, then we have a funding request and grant making. I mentioned our fundraising. Out of that, I'll give you a stylized example that we say from our allocation, 200 million for the next 3 years would be allocated to Indonesia. We invite the funding request by the country. It's the country that does the funding request and implements. So, but we also encourage the country to submit a funding request, not just for the 200 million, but what they feel is the full funding need if they want to reach the ambition of eliminating the disease by 2030. Let's suppose that they submit to us a funding request of 300. As long as we approve it for its quality, out of this 300, 200 will become the Global Fund grant for Indonesia tuberculosis, and the rest 100 million will stay there waiting to be funded as long as additional resources can be traced outside the Global Fund. That could be high net worth individuals, that could be private sector corporation donations, or it could be a debt swap. So let's suppose in this setting, Germany comes and negotiates a debt swap with Indonesia, whereby Indonesia, instead of repaying an ODA loan to Germany of worth 50 million, it channels those payments to us. Essentially, you swap. Instead of Indonesia paying Germany, they pay the Global Fund. And why the Global Fund? Because we'll take this 50 million, we will add it to the 200 million grant for tuberculosis. The grant will become 250 million, and we will use the same Global Fund systems to disburse, implement, audit, report that both Indonesia and Germany know and trust. So using those systems, we can implement at scale, cost efficiently, and in a way that it is country driven. And this is what has made Debt to Health, the debt swap program of the Global Fund, to repeat those structures over 12 transactions and create domestic funding for health to the scale of 226 million up to now, and with more transactions coming up in the future. I will leave it at that, and we'll see if Bryce can come in now to describe the Indonesia experience. There he is, and we can then discuss further in the Q&A section. Thank you.
Good afternoon, everyone. So having had that stylized example, it's always helpful to have a more concrete walkthrough of how a debt swap gets from start to implementation. So Indonesia's case, the latest debt swap with Indonesia is for 56 million USD, and it's primarily focused on tuberculosis. But it started in 2016 with the German pledge to execute debt swaps as part of their contribution to the Global Fund. From there, the Indonesian debt swap doesn't actually properly get going until the Ministry of Finance is formally contacted about the possibility of offering a swap to them in late September 2018. Then, in the steps and the terms of the process, a letter of interest has to be sent to the requisite German ministries to confirm that that Germany and Indonesia are indeed interested. Acceptance has to be given by all three parties, the Global Fund, Indonesia, and Germany, and that happened for Indonesia in late 2018, November. And then you have to go through the process of signing the document and the legal negotiations around the debt swap annexes. And that took some time. It took from the acceptance by the Germans of the debt swap arrangement in January of 2019, we go to November 2020. And then the actual release or signing of the debt swap formal ceremony took place in April of 2021. Why this is important to note is debt swaps take time to identify, to build the political consensus on your creditor and your debtor country's side, to find programming that fits the swap effectively, and then to actually execute. And this debt swap is still under execution, and we expect will be running for several years to come. So debt swaps are distinctly long tail transactions from their origination to closure. And it's important to note that that is an actual challenge of them per se. Very briefly, I want to highlight some of the biggest accomplishments in the Indonesia debt swap to date before a couple of general comments about what Indonesia can tell us about debt swaps and before closing. So in Indonesia's case, this is the debt swap has delivered some really tangible results for health. That extra 56 million has been critical. Indonesia is a high burden tuberculosis country. It's with a decentralized health system. And so this money has been critical to mobilizing additional financing. And there have been some really noteworthy results. COVID definitely negatively impacted notifications of people with tuberculosis. And as a result of the support that this debt swap has been able to bring, in part, we have seen those numbers in 2021 and 2022 climb to higher than pre-pandemic levels, which is a significant and noteworthy achievement. And on the community side of tuberculosis, there's a community grant that's associated with this debt swap as well. It's really important to note that we have seen some very interesting developments there. We have seen the formation of what our implementers are calling a TB army of former TB sufferers who are going out into the community, doing case finding and finding people who were diagnosed but never followed up a course of treatment. So we've seen some very interesting things fall out of this debt swap, very positive things for Indonesia. Very briefly, I'd like to comment on what Indonesia kind of can tell you beyond the fact that beyond itself. And that is, our experience has shown through Debt to Health that debt swaps really are better placed for one-off kind of projects. They're hard to replicate. They're hard to do repeatedly in a given country situation. So we echo the conclusions of the white paper, which points out that debt swaps are a good tool for increasing domestic financing, for targeted interventions in country, and for health system improvements, which are what the Global Fund has used its debt swaps to fund. The other element that's really important to note is where a debt swap's a good fit. And Indonesia shows another example of this in the sense that they are much more likely to be relevant for countries with a stable and large enough debt portfolio. So these are going to be your upper middle income and your lower middle income countries that have neglected disease issues, rather than lower income countries who need debt relief rather than debt swaps. Your Paris Club creditors are likely to be your best sources because a number of them have already executed swaps in the past, and some are currently actively doing so, as opposed to other sources, other significant lenders who do not have any track record. And thank you all for this. That's me.
Thank you so much, Bryce and Vlasis. That was excellent, and really good. As you ended, Bryce, talk about these one-off projects that make more sense for NTDs if we're applying Indonesia's TB example. So I think that was really helpful. Just move forward with the second speaker in this section. The second speaker will be Dr. Mona Hamami, who will speak about N prizes and milestone-based funding, which are the instruments that we highlight in the discussion paper. Dr. Mona is a partner at NZ & Company. She's a leader in the firm's public and social sector practice, where she advises public sector clients on development, employment, social policies, and macroeconomic policies. She's also a geographical leader in the Middle East for the McKinsey Health Institute, a nonprofit generating entity within the firm that aspires to catalyze action to add 45 billion years of higher quality life for all people around the world. She's committed to creating lasting economic growth through frameworks of strategic sustainable development. And McKinsey was a very strong partner with the group of experts that Glide led. McKinsey provided us a lot of information about work that had already been done, as well as led us in the prioritization exercise that brought us to these 4 instruments. So over to you, Dr. Mona. Thank you.
Thank you so much, Dr. Ngozi. It's a pleasure to be with all of you. So I think I would like to start by echoing a lot of what has been discussed before, that a lot of the innovative tools that we're discussing right now might not be as innovative in the sense that they've been used elsewhere. But in particular, I think what is distinctive about from the 4 options that we have, the milestone prize ones are probably the most targeted ones, in the sense that if you think about debt to health and debt swaps, they generally could be instruments that you could use for healthcare system strengthening. You can have debt to NTD, you can have debt to malaria, you can have debt to polio. But in the context of milestone prizes, they're a lot more targeted, and most of the time they're used for incentivizing R&D, particularly for discovery stage, but it also could be for late stage types of development. And then we've heard so much from Dr. Willow about the lack of investments in diagnostics particularly. And I think one particular area that might be very interesting for milestone prizes is for diagnostics in the context of NTDs. The 3 types of candidates in that context that are interesting is one, POCs for diseases that have none, right? And those you're probably looking for high burden and high demand. So leprosy, for instance, could be one of those. The second one is that you have a lot of mixed type of results for existing diseases, and there you would probably be looking for new innovations in that space. So that would include the category for visceral leishmaniasis, lymphatic filariasis, onchocerciasis, and some others in that category. Again, you're looking for high burden, high demand, and I'll explain a little bit some of the logic around that. And then lastly is how can you also crowd in funding beyond NTDs for multiplex diagnostics that allow you to have things like co-endemicity with things like lymphatic filariasis and LOA, similarly with LF and LOA, YOS, and syphilis. So some of those might be also interesting candidates to think about. Now, the advantage of milestone prizes, which is a pull mechanism, is that if you compare it to things that are like advanced market commitments, is one, they're slightly easier to sort of structure. But unlike AMCs, you have early on milestones that could incentivize payouts a little bit earlier in the mechanism. And so in that context, they could be a little bit more attractive. Now, where you could slightly fail to see how they could be useful is if you have a lot of smaller pieces of milestone prizes set up with no sense of the bigger view of the portfolio. And that's one of the issues currently in space, is that, you know, if you fund very early diagnostic work, to what extent are you really managing the noise? So some of the archetypes that has been discussed and sort of solving for that is, could you look for pooling mechanisms of funding? And I think in some of the discussions in the paper, we talk a lot about the pooling mechanism, but even for things around early discovery or even late stage discovery, late stage sort of investments for R&D, you could think about pooling mechanisms where you could garner several funders to come together to look at a portfolio approach for those types of R&D, which then allows you to have some form of scientific technical committee supporting this aspect to think about which of those portfolio are worth the investment rather than looking at siloed approaches of several milestones. So it's a hybrid type of milestone that could be looked into. The other part that is actually very interesting about milestone prizes is that they tend to a large extent decouple from pricing. And so that's an important mechanism to try and think about how do we create incentives to allow for impacts created. The advantage of them is that they also allow for management of impact risk, in the sense that the funders only pay out when you actually reach a particular milestone. That could be a milestone along the way, or it could be based on an end. I'll stop at that point, but I think we've seen the use of milestone prizes across the board for so many of the health technologies. XPRIZE is one big example. We've also seen them being used for NTDs, but at a smaller scale. So the prizes would tend to be around 25,000, north of 50,000, which are small amounts. And so one of the difficulties that we find is, can we scale up some of those milestone prizes? The other, similar to many of the other pull mechanisms, the difficulty of those types of arrangements is usually finding the right price. So what is the right price that will incentivize and cover the right sense of cost? And often that you find it's not just around covering costs. What you're really looking at is what we call reserve price, or reserve, as economists call it, which is sort of what is the actual incentive price at which you have all the incentives to actually start investing in the R&D element. And so those are the difficulties usually with pricing AMCs, pricing milestone prizes, and most of pull mechanisms is getting that price right. I'll stop at that point and happy to sort of engage in discussions afterwards.
Many thanks, Mona. That was really helpful and gave us some ideas also, not only about the type of entities that this is well positioned for, but some of the opportunities but challenges of the incentive structure for milestone-based funding. And I just want to stop here before I go into the next speaker to remind all the listeners that there are questions in the Q&A, and after you speak, or even before, if you see something applicable to what you're speaking on, you're welcome to just go in and answer that, and encourage the participants to continue to put the questions into the Q&A so that they can be answered. We will try to get to as many as possible at the end, but since we don't have that much time at the end and we did start a couple minutes late, it might be difficult. So I encourage you to do that. And I just want to once again welcome all of the audience members. In the chat, you can see we have people from all around the world. So it's great to have these conversations, and we look forward to engaging on this moving forward. Okay, back to the discussion. Our next speaker will speak on impact bonds, and it's Mr. Sherwin Charles. He's the co-founder and CEO of Goodbye Malaria, which is an African initiative to eliminate malaria in Southern Africa. Mr. Sherwin is also the chair of Global Citizen Africa, and he serves as well on the Global Fund, IVCC, and RBM Partnership to End Malaria on those boards. He spent the initial part of his career in the finance and banking industry in both South Africa and Nigeria, and he joined the Nando's Group in 2006, initially to finance and later to establish Goodbye Malaria. Whilst part of that group, he traveled with Kingsley Holgate into various parts of Africa, and it was during that period that he became aware of the extent of malaria and its disastrous effects on the young children across Africa, which really compelled him to do this work that he's doing in Goodbye Malaria. So over to you, Sherwin, to speak about impact bonds. Thank you.
Thank you very much, Ngozi. And thanks for the opportunity to have a discussion about our journey with the Malaria Impact Bond, and our journey over many years to put a bond in place for Southern Africa. I think the discussion paper outlays very clearly what an development impact bond is, and shows the complexity of the structure of a bond. And when you have a look at the diagram in the paper, it very quickly gives you a sense why these have been so difficult to implement, why implementation times take so long, and how do we successfully look to utilize this instrument for NTDs. I think the bond principally made a lot of sense. It said, we could give private investors an opportunity to take on risk and to really assist in a development challenge, whether it be in public health or otherwise, and then have an outcome payer, particularly a government, some other donor, or a corporation, who would then look to repay the initial investment plus a potential return on that investment. The challenge we faced in malaria was when we spoke to donors and we were looking for funding, it was quite an easy discussion compared to having a development impact bond discussion. And the reason for that is a donor understood that they were going to support us. This is what the impact we were going to look to achieve, and this is how we were going to deliver the service to the community. When we started having those discussions around the same application, but packaged as a development impact bond, the discussions became a lot more difficult. We started having discussions with different teams within the organization. We were starting to have to measure risk that would be transferred. We were working on M&E structures and frameworks, and one of the things that the development bond required was really the existence of a proven intervention that has been effective, that has been fit for purpose, and that was relevant to the geography. And the challenge within the malaria world was that the data was sometimes not as reliable and consistent as one would like for us to develop models that could allow us to define returns and risk and reward within a complex bond structure. Now within finance, that's quite easily done. We all understand risk and return and interest rates, but you don't have that same relationship within the development environment. And so what we've seen is a lot of trials that have been run or small amounts in a bond utilized as a trial, and then looking off that to develop a much bigger intervention. The challenge with it is that the implementation costs of development bonds are extremely high. And we found that we'd spent a lot of money on lawyers' fees, really trying to align all three parties to the same outcome, to the same timeframes, and getting a clear understanding and acceptance of the risk. What we did see develop and where we ended up was really more closer to a outcome contract, where you're looking to attain a particular outcome and then having an investor fund that. It turned out that the costs and the time that it would take to really put a malaria bond in place was significant, and we found an easier solution. This does not mean that the impact bonds do not have a place within NTDs and within development funding, but I think it takes a lot more work and a lot more effort to achieve it. And it needs the cornerstones of good metrics, good data, and really a clear understanding of the impact against the metrics and how one can monetize that. And so, a time frame of 3 to 5 years to put a bond in place is realistic. Thanks.
Excellent, excellent, Sherman. Thank you so much for that insight. Just because we're running low on time, I'll just move straight to our next speaker, who will be speaking on pooled procurement. And that is Dr. Ariane McCabe, who is the lead for global health policy and advocacy at GlaxoSmithKline. She joined GSK in 2018, and she has more than 15 years of experience working in global health. She's worked with several development organizations at the global level and Saharan Africa on policy, resource mobilization, partnership development. Over to you, Dr. Ariane.
Hi, everyone. It seems to be really fuzzy on my screen. I don't know why that is, but let me kick off and hopefully that will improve as we go. I want to say a big thank you to the GLIDE team for inviting me to talk about GSK, our work in ensuring access to global health products, and more specifically on our experience with pooled procurement. And I hope that these comments will provide some food for thought in terms of thinking about pooled procurement for NTDs. I want to start by situating our experience with pooled procurement more generally in GSK's work in global health. Certainly at GSK, we see our purpose is in uniting science, technology, and talent to get ahead of disease together. And global health is a key cornerstone of our corporate ESG agenda. In terms of our global health ambition, we're really focused on reducing health inequalities by looking at and targeting high burden infectious diseases that impact lower income countries. And to do this, we've got a three-pronged approach. The first one is really to look at global health R&D. And through this, we're developing new medicines and vaccines against high burden infectious diseases in low income countries. We're also working on capability building and building partnerships to strengthen health systems and ensure that our innovation gets to the patients that need it most. And finally, I think most relevant for this group is really looking at how to ensure and pursue equitable access to our global health, our GSK portfolio, and our pipeline products. And so some of the key programs in our access work include our supply of vaccines to Gavi. We've got three vaccines that we currently supply to Gavi. We're also working on improving access and ensuring access to our malaria vaccine, RTSS, and we have been doing this through the malaria vaccine implementation pilots in 3 African countries, and later this year, they will be introduced in Gavi countries through Gavi-funded supply. We also supply oral polio vaccine to UNICEF and the Global Polio Eradication Initiative. And probably familiar to this group, we have a longstanding commitment to our albendazole donation program, which we started back in 1999, which contributes to and supports the elimination and control of lymphatic filariasis and STH. So we're delivering more than 500 million tablets a year for this. And I flag these different access programs because many of these use pooled procurement to ensure impact and scale. So for example, last year, GSK reached over 1 billion doses supplied to Gavi since 2010. And for oral polio vaccine, we supply about 95 million doses a year. So those are significant volumes that we're able to achieve using pooled procurement. And I think when we think about the different access challenges along that continuum of product development to access pathway, certainly the financing and procurement elements are really important to consider. And as you point out in the paper, pooled procurement isn't an innovative finance tool, but it is a really important tool that does offer significant benefits for both suppliers and countries. So what are some of the benefits that we see as a manufacturer and a supplier of pooled procurement? And I think many of these that I'm going to mention echo the comments and those benefits noted in the paper. But here I'll really draw from our experience with our Gavi UNICEF pooled procurement supply. So the first one I want to flag is really mechanisms like Gavi and its pooled procurement agent UNICEF are really able to aggregate demand from many, many countries. Today, there's something like 53 Gavi eligible countries. And in addition, there's many more lower middle income countries that are also able to now access Gavi UNICEF pooled procurement facility. The second one I want to mention is really around aggregate financing. And this is important because Gavi UNICEF is able to pool the financing from countries, implementing countries, and donors. And it really provides suppliers such as ourselves with confidence that there's going to be a buyer or a payer for our products. And so over time, this really gives us a lot more visibility on long-term demand forecasts, and it really improves our demand certainty. On a more practical level, having one procurement agent means that companies can negotiate one contract, and that really reduces the contracting complexity and avoids having many small tenders. And I think we think that this really ensures a better managed supply chain overall. In our experience, we also are offering a single product presentation for these large volumes. And that is also really helpful because it reduces our manufacturing complexity, it improves manufacturing performance, and it potentially reduces the cost of manufacturing. And so overall, I'd say that this also, pooled procurement also facilitates manufacturing and supply planning. And that is certainly critical for us in terms of our work. The other important element that I want to flag, and I think it's a kind of common thread that I've mentioned in my remarks so far, is that pooled procurement is really helpful in reducing risks and uncertainty and complexity. And in particular, it reduces the risks for us in making long-term investments. And these investments can include investments in manufacturing scale-up, but they can also include, for example, investments in bringing new products and new innovations to market. I also want to highlight that I think overall, pooled procurement is a tool that can offer certainly greater access at scale. It can offer opportunities for market shaping. It can help reduce the market fragmentation. It can lower prices, as I've mentioned. It can offer greater supply security. It can offer potentially more reliable supply to countries. And as I mentioned, it can potentially also offer access to new innovations. Before I close, I just wanted to highlight some of the key elements that are, I think, important for us in terms of ensuring that pooled procurement works well. Certainly, it goes without saying that it's important to have a secretariat for the pooled procurement mechanism or instrument. It's also important to have financing that can be aggregated to support this work. But I think maybe some of the elements that are not always considered is that to ensure aggregated demand or have aggregated demand, it's really important that that's underpinned by product demand. And so there's a lot of work that has to go into ensuring awareness of products through ongoing active demand generation and evidence-based decision-making at the country level about product selection. Other important elements that I want to flag are certainly around timely regulatory approvals, as well as political will to ensure that there's country readiness to take up products when they're available. And this also includes appropriate and sustainable financing at the country level, but also prioritization of disease programs in general. And the last element I wanted to flag that for us as GSK, tiered pricing is also really important in terms of pooled procurement. And this is certainly a principle that we've applied for at least 25 years for our public market tenders. And we really base our tiering on country income levels. And in this case, it's really based on World Bank classifications. And that means for us, we're able to ensure that products are available, they're affordable, as we set prices at levels that allow patients across all income levels to access products. And it's also important for us because it allows us to operate in a sustainable way that allows the business to continue to supply and innovate high quality products. So maybe I leave it there, and I'm very happy to answer any questions in the discussion later.
Thank you very much. And your voice was very clear, even though we were unable to see you. But thank you so much for your remarks. I think that our next speaker, Martin Edlin, will be able to really kind of pull together all the different elements of what our colleagues have spoke about today on the four instruments, but also give us a wider understanding of like what are the steps and the efforts that need to be done when you're going into financing or developing a finance mechanism. Martin Edlund is a founding member and CEO of Malaria No More. He leads strategies to substantially increase global resources for innovative global health programming and malaria. Martin serves as executive director of the Health Finance Coalition, which is working to scale private and blended finance investments to achieve Africa's public health goals. The coalition is led by Malaria No More with financial support from the Rockefeller Foundation and the MCJ Amelior Foundation. Martin has lived and worked in West Africa as Malaria No More's director of new programs, where he helped launch novel mosquito net distribution, fever testing, and public health education campaigns with leadership and telecom partnerships across Senegal, Cameroon, Chad, Nigeria, and Tanzania. So without further ado, over to you, Martin. Thank you.
Thanks so much, Ngozi. Great to see so many friends and fellow travelers on today's call. As you mentioned, I'm Martin Edlund, CEO of Malaria No More, the Health Finance Coalition Executive Director, and also an ambassador for the Global Fund 7th Replenishment. So great to see a lot of our Global Fund friends and colleagues here. I think my role is really to talk about kind of the adventures and misadventures we've had in blended finance to date. Historically, Malaria No More has worked on financing for the malaria campaign, as the name implies, and we focused in the first really decade on public sector sources. We were looking at how to mobilize US and UK and Japanese and other investments into vehicles like the Global Fund, the US President's Malaria Initiative, and so forth. But one of our founders is a gentleman named Ray Chambers. Ray invented the leverage buyout and comes from the world of high finance. So we've always thought about how to straddle these realms of public health, public finance, and private investment. Our work in this area started about 5 or 6 years ago. We led the development of something called the Regional Malaria Elimination Initiative, a $187 million blended finance facility targeting additional capacity and financing to end malaria in 8 Central American countries. That was done with the Inter-American Development Bank and some other partners. And that experience led us to create the Health Finance Coalition 3 years ago. Isatu, do you mind going to the next slide? And so we're really trying to respond to the same challenge that we're all talking about, the massive gap between the world's ambitions for health and our means, our resources to accomplish it. The Health Finance Coalition has the explicit goal of trying to scale private investment for public health goals. And so we started by convening partners, the logo soup that you see at the bottom, a lot of the public health, major donor partners like the Global Fund, like the World Bank, like the WHO and USAID, and some of the kind of more forward-leaning and innovative philanthropies, the Gates Foundation, Rockefeller and Skoll Foundations as examples. The bar that you see there is kind of important to how we approach the world. We talk about taking a capital stack approach, and that phrase is kind of very common in the world of finance, but it's not how we typically think about health interventions. And so the idea of a capital stack approach is, how do you bring government spending, grant dollars, concessional debt, and various forms of return-seeking investment into alignment, investing in the same sectors, even investing in the same deals. Next slide, please. So our thesis and theory of change was, it's not enough to just bring people together to talk about these things. There's a lot of talk and magical thinking, hopeful thinking about innovative finance. Our approach from the beginning was, let's put deals on the table. Let's try to show a way forward by structuring and financing some deals. And so we set the initial goal of doing a demonstration deal and a demonstration fund. Happy to report 3 years into this effort that we've achieved those first 2 goals. So the demonstration deal was a $35 million loan guarantee facility, something we worked with the US Development Finance Corporation and philanthropic partners to backstop loans to frontline clinics across 5 African countries. The next level of scale was the Transform Health Fund, which we just announced at the US Africa Leaders Summit in December, hosted by the White House and involving many African heads of state. So this is a $100 million fund focused on supply chain transformation, innovative care delivery models. And I'll talk a little bit about kind of how we learned as we went with that. Next slide, please. So the first two that I mentioned, the Open Doors African Private Health Initiative and the Transform Health Fund, these are the things we've done to date. But our goal moving forward is to try to work with partners, not to do everything ourselves, but try to catalyze the next level of scale in blended finance solutions. And so you see on the right a couple of things that we're kind of incubating and working on now. The Outcome Fund for Fevers, which we announced as part of Global Fund Replenishment, working with Global Fund and Chai and other partners on that. And then some work we're doing mostly with regional development banks, thinking about how to scale exciting new dengue technologies like the Wolbachia technology that many of you may know about. Probably the most helpful thing, hopefully the most helpful thing I can offer in this conversation is just a few lessons from kind of what we've learned doing this over the last 5 or 6 years. And so I have four lessons that I'll just touch on briefly. First is you need to pick the right problems. There is a real kind of tendency for magical thinking around innovative finance. When you kind of run out of options in terms of domestic finance and donor aid, you think, well, innovative finance will fill the gap and solve the problem. But you really need to look at problems that are amenable to investment. Look at where there are cash flows that you can capture to repay investors. You know, we talk a lot about ROI in health, and you know, the ROI case for NTDs is compelling and profound, but the ROI has to be not just calculable, but actually capturable so that you can get those cash flows to repay investors. So things like recurring costs for bed nets or community health workers, in my view, are probably not good candidates for blended finance solutions. We need to be looking at things like some of the upstream ideas I'm hearing today around innovation, market shaping, manufacture for these kind of investable deals. Second lesson is to pick the right investors and instruments. You know, we talk about investment in health as kind of a single term, but when you look at the motivations and return expectations of different kinds of capital, they range pretty widely. And you know, I saw this reflected in the paper. A program-related investment from a foundation is very different than concessional debt from a multilateral development bank, is very different from a guarantee or investment by a DFI. And then you've got commercial investors at the other end of the table or other end of the spectrum. And so you really need to pick the right investor and the right instrument for the problem you're trying to solve. I mentioned before the Transform Health Fund, and we're at about 70 million of that 100 million raised to date. You know, we originally started with a pretty different concept, and we polished that stone through talking to investors and partners. We were originally looking at making equity investments into businesses in Africa, but we realized that what they really needed was debt. Most businesses in healthcare in Africa, particularly serving the segment of the market that we wanted to reach, they don't have the exits or the liquidity events to justify equity investments. You know, we're trying to invest through the Transform Health Fund in the areas of greatest need. So we had to really bring down the cost of capital for those pipeline companies. And so we structured that with 2 pools of capital, commercial and catalytic capital, that we blended to bring down the cost for those underlying companies. And then we ended up making it quite a long life fund, really kind of stretch the boundaries of what our investors are accustomed to doing, because we knew we had to be patient investors in these underlying businesses. And so that brings me to, I'll combine the last 2 points. You need to engage the right expertise and partners to do this work. and you need to get tough feedback early. Transform Health Fund is a joint venture between the Health Finance Coalition and a group called Africa Invest, one of the top private equity and venture investors in Africa. And the people who are running this have deep backgrounds in structuring these kind of deals and advancing them. A lot of us deal with aid agencies, but there's an entire parallel world of DFIs, and they look at the world very differently. They evaluate opportunities very differently. So, there's USAID in the US, and then there's the DFC. There's FCDO in the UK, and then there's BII. And the way that they evaluate deals is they put them through really rigorous due diligence. They put them in front of investment committees. They scrutinize them in a way that's very different. So you need the right capacities and skills and experience on your team to develop those deals, and ultimately to kind of see them through. And so getting tough feedback early is one of the best pieces of advice I can give, because it's going to allow you to adapt and evolve these ideas over time. We have a body of work that we call deal construction, and the idea is to support high impact businesses to help make them investable by commercial investors over time. But before we start on a deal construction engagement, we actually share that with the Africa Invest team, and we talk to them about what it would take to make the company in question ultimately investable. So there are no illusions going in and no surprises going in. And if the candid feedback is this company is way too early stage, there isn't really a path to investment for them, that's informative, and we probably won't engage in the deal construction work. So I know we're over time. Let me stop there, but thanks for having me, and really interested to hear the rest of the discussion today.
Thank you so much, Martin, especially for joining so early. I think it's around 6 a.m. Seattle time, so we really appreciate that. And very impressed you had such clarity so early and gave us that information along with the 4 clear lessons learned from your experience with the Health Finance Coalition. I think we'll get back to some of those lessons at the end, but I want to now give time. Well, first, I'm going to ask from everyone if we can just have an extra 10 to 15 minutes to finish the conversation. We really want to hear these reflections from the GLIDE CEO Bland and the acting Africa CDC director, Dr. Ahmed. So if you can stay on an extra 10 to 15 minutes, please do. Otherwise, we will have the recording and a link to the discussion paper that we will share with all registered emails at the end. So let me now introduce our final 2 speakers. So Dr. Ahmed is the acting director of Africa CDC. He's also the founding deputy director of Africa CDC. And in these roles, he has led the strategic work and oversight of the institution. He works closely with the African Union member states and partners to deliver on the mandate of Africa CDC of preventing and controlling diseases in Africa. Dr. Ahmed has led the operations of Africa CDC during the COVID-19 pandemic, which included coordinating, planning, acquisition, and delivery of life-saving health products to African countries, including test kits, personal protective equipment, therapeutics, and vaccines. Formerly, he worked with the WHO at both headquarters and the Afro regional office, and he worked on combating NTDs and tobacco control. He's also worked at the country level in the Ministry of Health in Kenya as the director for NC non-communicable diseases again, and then was the head of the Office for International Health Relations. And then finally, we have Simon Bland, who is the CEO of GLIDE. Simon has over 35 years of international development experience, straddling marine and natural resource management, developing economics, and global health. He joins GLIDE after 6 years as the director of the UNAID New York office. He began his journey as a volunteer with the Voluntary Services Overseas UK organization and in Papua New Guinea, and then joined the UK's Department for International Development, where he led country programs in Russia, Ukraine, Kenya, and Somalia. He's currently the vice chair of the board of the RBM Partnership to End Malaria and is a trustee of Malaria No More UK. He's also a member of the Forum on Public-Private Partnerships within the National Academies of Sciences, Engineering, and Medicine in Washington, D.C. And he was the chair of the fund in 2011. Okay, so that's very, very big portfolios and experience for both of our final speakers. And we look forward to their insight and reflect on this very meaningful but very complex issue that we've discussed today. So over to you, Simon and Dr. Ahmed. Thank you.
Thank you, Ngozi, very much. Dr. Ahmed, just let me check that you can hear me and you're on. Do we have
Dr. Ahmed, we're having, go ahead, Simon, go ahead.
Do we have Dr. Ahmed on the line?
He's on the line, but we're not hearing you, Dr. Ahmed. We can see you, but we don't hear you.
Hear me?
Yes, now we can hear you. Thank you very much.
Yes, we can hear you. Thanks very much. Let me just say a couple of words of reflection, and then I have two questions, Dr. Ahmed, for you, if I may. First of all, I'm really excited to see such a large contingent joining us at the very beginning of a conversation, and this is going to be the beginning of several conversations we're going to have. We've got folks from the world of NTD, from broader health, from malaria, and it's great to see how we might learn lessons from one another. As Dr. Sose talked about his journey being young in terms of NTDs, the GLIDE's journey is very young. We're just 3 years old. But we recognize this changing funding landscape that we've talked about. We understand the challenges and discourse around vertical, horizontal programming, integration, not as a philosophy, but as the nitty-gritty of delivery. We understand the incredible impact that donations programs have had, but also recognize the questions of the commitment that is there, but the concerns around sustainability. Ngozi used the phrase at the beginning, what got us here won't get us to where we want to be. How do we get better tools? How do we use the tools that we already have better? How do we incentivize the discovery, research and development of new approaches? I heard about the ambition and big bets, particularly the economics of elimination and eradication. There's a whole conversation we could have about that, helpfully from Willow. And also, yeah, I mean, I think one of the big questions I'm going to come to you, Dr. Ahmed, is really over the word neglect and neglected diseases. So many of the tools we've talked about, we know they've been applied elsewhere. Martin talked about misadventures in blended finance. I really liked your lessons, Martin. Pick the right problems, engage the right people, get tough on feedback early. So I'd like to get tough on feedback early in this conversation if we can. You talked about the return on investment case being strong and compelling. I question that, actually. I'm not sure how strong and compelling it is, given the opportunity costs and others, but I really liked your message of it being calculable and capturable. So, Dr. Ahmed, if I could turn to you first of all, and I'm really struck by your journey to this role at CDC, and a phrase you used a little while ago. I strongly believe that we should use local capacity to solve local challenges while harnessing international experience, knowledge and skills. I think that really encapsulates what I think we want to try and do here. And so given that the vast majority of the NTD burden exists on the African continent, how much of a priority do you see NTDs getting to both the CDC and to your member states, especially given all the competing high burden diseases that also demand increased attention and finance?
Thanks, Simon, and really fastest gratitude to the organizers, the seeing Ngozi here, for inviting Africa CDC to be part of this, so we can share some of our reflections where NTDs are concerned. So the simple answer is yes. NTDs are a very big priority for us at Africa CDC. Indeed, it is a growing priority for our member states of the Africa Union as well, because different countries are affected differently. And therefore, trying to get all countries to be on the same page does take a little bit of discussion and consensus building. But at Africa CDC, NTDs, very big priorities. And I'll give you 3 reasons why, some of which you touched on as you were introducing today's discussion. And other speakers actually had also touched on some of these. But for us, it boils down to 3 things. One is, well, the context is 90% of NTDs are found on the continent. So by extension, anything that needs to be pushed, anything that needs to be done, if it does not involve the continent of Africa, then there is very little chances of success. Any conversation, any consensus building, any capacity building needs to actually first be done here on the continent before it goes elsewhere. But the 3 reasons is, one, diagnostics. The vast majority of the NTDs as listed by WHO, the 20 of them, there are no effective diagnostics. And if you cannot be able to diagnose, then you cannot be able to manage effectively. And this has been a huge stumbling block in as far as our expansion of control and elimination of NTDs here on the continent is concerned. The second is, those who are affected are the most vulnerable. They are the ones who don't have voice. Even amongst the voiceless, they are still voiceless. And the continent of Africa has been voiceless for quite a while, something that we are trying to change. So the vulnerability of the populations that are mostly affected means that the visibility of NTDs is low, and it only becomes important when a tourist or a visitor to a particular area does get exposed to these NTDs. But by and large, it is very vulnerable populations who don't have much of a voice. And the third is the opportunity cost. And I divide this into 2. The reason why it is really a priority for us. If we do the right things, there is very high chance that we are going to eliminate most of these NTDs, if we do the right thing. Unfortunately, if we don't do the right thing, then the risk of spreading beyond the endemic areas also increases because of the nature of our engagement in the world today. We travel, we go into different communities much faster and more regularly than we did before. So that third one is the opportunity cost. If we do right, we can eliminate. If we do wrong, then it can be able to spread. So for these 3 reasons, Simon, really NTDs are a very big priority for us at Africa CDC and for the continent as well.
Thanks, Dr. Ahmed. It's really interesting. And I think I love that last point on that opportunity costs. Do the right things, do them right. And if you succeed, the benefits are huge. And this was the point Willow made right at the beginning, which is you need a big bet, you need to be bold, you need to be ambitious, you need to get the job done. And we're seeing country after country shrinking the map and eliminating. We're seeing transmission being interrupted. So the concept is there. Yes, we've only had one global eradication of a human disease thus far, but there will be more. But we need to stay the course and we need to invest. I think that's super important. And the economics of recrudescence, the economics of as you said, spread, and perhaps the implications of climate change and increasing latitudes and altitudes and vector spread. So I think that opportunity cost is huge. There must be things we can do on visibility through advocacy that will help, and other organizations working on that, and the challenge of diagnostics. But when I think about some of the innovations of finance that people have talked about, it's that perennial question. So we heard from the Global Fund about a debt swap. Part of that conversation has got to be, what if there is a debt swap deal that can be done, what is the compelling case for that deal to be done, targeted at NTDs rather than targeted at something else? So that's going to be a perennial challenge we have around neglect and neglected diseases. Dr. Ahmed, the final thing I thought would be really great to hear from you about is around the new public health order that you've talked about, CDC has talked about, I think John Gengasong talked about it. But so how is the CDC leveraging this new public health order to work with endemic countries, with industry, with other stakeholders to help create this sustainable and African-led system of research, development, access, delivery, new treatment, new diagnostics? Perhaps you could tell us a little bit about that, because you see this is hugely exciting. This is the new paradigm. This is the new world. This is the changes that we all want to feed into and support. So it would be great to hear from your side the perspectives of CDC.
Yeah, thanks for that. Let me start by stepping back a bit. Our experience in prevention, control, response to health emergencies on the continent has taught us that you are better off when you overreact. When there is any outbreak or health emergency, overreact. I would rather we are debating that, you overreacted, but then there is no outbreak, instead of you go in really gently and then suddenly you have a whole city that you want to put on lockdown. So overreaction is really the hallmark of what we need to be doing when it comes to disease threats and health emergencies. Which brings me to your question around when we look at NTDs, how are we approaching that as Africa CDC? Our new public health order is has been very effective as we implement it during the pandemic. In fact, by the way, we started before the pandemic, but then when the pandemic came, we were able to scale it up and the results have been very good. NTDs is a relatively new area for us because Africa CDC is 6 years old. We've been chasing the more emerging sort of pathogens. Now we are going back to endemic and NTDs now that things are sort of settling down globally. In Africa, we still have Marburg virus now. We have Ebola we are still battling with. We have cholera as well. So although it is a relatively new area, we are using the model that we know works. We are adapting it based on the pathogen and the area where the outbreak is, but we're using the same model, new public health order, which has 5 pillars. The first is strengthening of health institutions. And for NTDs, as Africa CDC, at the continental level, we have a whole work area that is headed by a head of a division to look at endemic diseases and NTDs. So we are strengthening that coordination and convening role of Africa CDC on the continent. And that's how we are strengthening. Second is we are strengthening our member states' institutions that deal with NTDs. Most of them are doing this through the Ministry of Health. And of course, every so often, the ministry is responsible for wildlife and agriculture will come in, but basically it is the Ministries of Health. So we are building their capacity as well because they are the implementers. And we believe very strongly that when this pillar is fully implemented, where you have strong coordination at the continental level and a strong agency to deliver for the communities at national level, we will be able to walk the journey of elimination more strongly. Second pillar is on workforce. And we want to strengthen workforce based on need. This means that for NTDs, we are looking at what kind of professionals do we need for the NTDs to be identified where they are, and then the communities to be engaged, and the conditions to be managed, and the pathogens, of course, to be eliminated where possible. So when we build our health workforce around the needs, and the needs will be different from one country to another, but when we build that workforce, it means that the capacity locally will deal with one NTD and then the next one. And when that country has eliminated, that capacity can be used with its neighbors and even further beyond. So that's the concept that we are taking for the African continent to be able to share its resources, particularly human capacity when it comes to neglected tropical diseases. Third is local manufacturing. I'd started by saying that diagnostics are a problem. And of course, even therapeutics are a problem. So what we are doing is NTDs are on our list of priority diseases for which we need to develop diagnostics, therapeutics, and vaccines, depending on which disease we are talking about. And local manufacturing also, the other thing that we are doing is we are engaging with those who hold intellectual property to molecules that will be beneficial to us here on the continent. And then we are mobilizing private sector to be the recipients of this technology transfer so that we can manufacture what we need here on the continent. But it goes beyond the complex things like diagnostics, therapeutics, and vaccines to more simple things like what do we need for prevention, right? And there'll be basic things. How do you deal with water so that it is safe? How do you deal with your environment so that it is safe? How do you deal with your neighbors, your family members, so that you're not transmitting to them? So all these innovative ideas that we need for prevention and control, we want to innovate them locally. And when we are not innovating them locally, at least we are manufacturing them locally. That's the third pillar. The fourth is domestic resources. Domestic resources doesn't mean money, but money is important. It means where is the expertise? Where are our academic institutions? Where are our research institutions? Where is the private sector? Where is the public sector? So that we bring ideas around a table, and the ideas that need money, we go and look for the money. And that money, we are also insisting it must be local money first. The government putting their own budget on the table, our local philanthropies and the private sector also putting their money on the table to be able to finance those local ideas that we have identified them as good. So resources, we look at it from a very broad perspective. And then when there is need for more, then we can knock on doors that are of our neighbors and of friends of Africa who are willing to help when it comes to NTDs. The fifth pillar is partnerships. We are convinced we need to do this on our own, but we are also very pragmatic. We know we don't need to do it alone. So we invite friends of Africa who have the opportunity to be able to support our vision and ambitions to help us where we have gaps. And that help must have two characteristics. The partnerships we are talking about must be action-oriented. They must produce results. It is not partnership where we have a beautiful 4x4 air-conditioned vehicles in our communities, and there is little that is changing in the communities. This kind of partnership we don't want. We want results with partnership. Second characteristic of this partnership, that they must be based on African priorities. So when we say pathogen X is the one that we want to tackle, let's focus on pathogen X. Don't give us solutions for pathogen Y, because that will take our time and capacity away from what is our priority into something that may not be a priority at that time. So this is the way that we're using the new public health order to address NTDs, and looking at the strategy that now we are finalizing. We will start active implementation based on those 5 pillars, and then based on which countries need support first, as we aim for elimination on the continent, one NTD at a time.
Asante Sana, Dr. Ahmed, that was super helpful. I'd love to have another hour, and perhaps we could do a follow-up call and do a proper conversation. This was a brilliant way to end this beginning conversation for us. I'm going to hand back to Ngozi, but let me say thank you very much. I mean, I hope we've got 19 pathogens and snake envenoming on the list as well, but it's driven by African needs. It's driven by African priorities. I think that's hugely important for us. I've learned a lot today. I think there's a lot of things to be excited about, but so much work for us to do. So once again, Asante Sana, Dr. Ahmed, it's great to see you. Thank you for joining us. Let me hand back to you, Ngozi. Thank you very much.
My pleasure, Simon. Thank you.
Thank you. Thank you.
Just to thank you, Simon and Dr. Ahmed. I mean, not much to say because we've gone over. I've put my thanks in the webinar chat, but just to say it's excellent to bookend this conversation, starting with Dr. Sose, who is leading NTD program at WHO in Geneva, and then to end, Dr. Ahmed, like he said, 90% of the burden for NTDs is on the African continent. And so nothing can be done without Africa, and it must be led by African countries. So it's excellent to see this high level buy-in. And we invite you all to continue to be part of these conversations as we work towards a resolution for innovative finance mechanisms for NTDs. With that, I'll just bid everyone adieu, and thanks everyone, especially the GLIDE team and our stakeholders who contributed to the discussion paper. Thank you very much. Enjoy the rest of your day.
Thank you.